All right. This is my first attempt at doing a vlog or a video blog or whatever, but I've been asked to do it in response to the coronavirus pandemic issues we're having. So, just as a disclaimer, I'm speaking straightly from my own opinion. I am not representing any group or anybody else. This is strictly about what I know based on my knowledge about infection control, viruses, things like that. I am a registered biosafety professional through the American Biological Safety Association, but I am in no way speaking on behalf of them. Again, I'm not giving medical advice. I am not giving any sort of, uh, you know, uh, criteria for you to then take and say, well, I heard on the internet, right? Anything I say, by the way, you should probably verify. And the best place to verify is through sources such as the CDC or your state Department of Health. Every state right now has probably very similar information about this virus where you can go to and ask all kinds of questions. I'm going to try to attempt to answer as much as I think is important. If you have any questions, you can always message me. I've already been receiving a lot of messages regarding and questions about this virus and what to do. So let me go ahead after having said that. First things first. All right. So let's start from like the top and work our way through this muddled, confusing field that's called virology and epidemiology and infection control and all these things. So let's start with the basics. So what is a coronavirus? So a coronavirus is a type of virus, and there's many different strains of this virus, okay? Like the flu, there's many different strains. Like HIV, there's different strains. Like Ebola, there's different strains. Whenever you're talking about viruses, you're talking about different types that are similar. It's sort of like a family of viruses. Now, what makes this virus unique is that it is normally different, less virulent strains of coronavirus cause things like the common cold. So every time you go to a doctor because you don't feel good and you got a stuffy nose and you're, things like that, and tell you it's just a virus or it's just a bug, a lot of times it's probably a coronavirus, okay? So, and it can cause various degrees of illness. Now, coronaviruses are, again, like different types of strains. In, I think it's the early 2000s, 2003 maybe, it was discovered that there was a new strain of virus that was causing a lot more than just a common cold. And that's what we ended up calling the SARS coronavirus, which was SARS coronavirus 1. Okay, SARS stands for Severe Acute Respiratory Syndrome, SARS. So this specific coronavirus strain was causing some pretty nasty illnesses, and we were afraid it was going to go pandemic. Luckily, it did not, and I think it affected about 8,000 people or so, but we got it under control. So then moving forward, I think it was in 2000, later in 2000, I can't remember the exact year, we had a second type of coronaviruses that we've never seen before, which caused the disease MERS. And what MERS did is what it was called Middle Eastern Respiratory Syndrome. And MERS caused, again, similar types of respiratory distress. And it, again, we thought it was also going to go, pandemic. And the thing about MERS is that 3 or 4 out of every 10 patients reported with MERS ended up dying, which is pretty big. MERS started in what we think is in the Arabian Peninsula. It was around 2012. But they think, they weren't really sure where, exactly it did start. But the Arabian Peninsula has been what was linked to this MERS coronavirus. And the largest outbreak of MERS outside of the Arabian Peninsula occurred in the Republic of Korea in 2015, which was what started getting people afraid of this going pandemic. Um, and it did spread with ill people through close contact, just like SARS did. But these were people that were caring for people that were living with MERS, had an active infection. So, um, you know, we still continue to monitor SARS and MERS, but we haven't seen a SARS outbreak since 2002, 3, or whenever it was. Now we're seeing this third new coronavirus, and we're calling it SARS-CoV-2. So SARS-CoV-1 was the original SARS. It caused the disease SARS, and CoV means coronavirus. So SARS-CoV-2, which is this new one, is SARS coronavirus 2, new strain, and it causes the disease that we're calling now COVID-19, which stands for coronavirus disease in 19 for 2019. But so that's what COVID SARS 2 versus COVID-19. You might hear both of those. SARS-CoV-19 is the name of the virus versus COVID-19. I'm sorry, SARS-CoV-2 is the name of the virus versus COVID-19 is the name of the disease. Sort of like how the HIV virus, human immunodeficiency virus, causes the disease AIDS, the autoimmune disease syndrome. So this is kind of a rundown about the terminology and what this virus is and why we're seeing this new virus. It's not necessarily a new virus, but it's a new strain of a virus that's very well characterized and very well known. So, but the thing is about, as viruses mutate and change, they can behave vastly different than their cousins. So this is why this is a concern, because this is a new virus, and all we know about it is that it's spreading like a wildfire from person to person contact, usually through close contact, which is defined as being within 6 feet of somebody who has an active infection, who is coughing and sneezing, or if you are living with somebody who has the infection and they're touching doorknobs and faucets, and you're touching those same doorknobs and faucets, and then eating food or rubbing your eyes or touching your face, which then transfers that virus into your system. So we do know a couple things about this virus, one of them being that it is and this is a recent revelation, is that it can remain active in the air on droplets. So if somebody sneezes, when somebody sneezes or coughs, your body projects different size of basically droplets of spit, mucus, and whatever. And some of these droplets can stay suspended in the air a lot longer than others. Some of them will just immediately fall to, and land on whatever surface. But some can stay in the air. And it's those little ones that stay in the air for a little longer that we think may be related to this idea of what we call an airborne infection. Although it's more, there's usually not a lot of these larger droplets when one sneezes. So, so we think that it's mostly a, droplet exposure, meaning you touch a surface, you touch your eyes, therefore, Now, if you're sitting within, and the reason why we use the 6 foot rule is because 6 feet is about the distance that, spit and things like that travel when you sneeze. If you sneeze, your droplets can travel about 6 feet. So that's where that 6 foot rule comes from. But I think that, in my opinion, is that this is mostly transferred through what we call fomite exposure, which is basically touching things that are contaminated. So if I sneeze on a door handle, or if I sneeze in the bathroom and my infected, sneeze droplets land on, say, the faucet handles, and then somebody in my household comes in and is ready to brush their teeth, and they turn on the faucet, and they grab toothpaste, and they're working their toothbrush, and all of a sudden, they get their hand, kind of close to their mouth, and whatever, it can spread that way. So I think that's the biggest way this virus spreads. So having said that about this virus, now, um, these types of virus, and by the way, the coronavirus is it's similar to the flu in some respects, but it's very different in how it manifests itself in disease. um, so when people compare coronavirus to the flu, it's not the same thing. That's like comparing a dog and a snake. They're both vertebrate animals, but they're vastly different. And that's the same thing, the same type of situation we have with like the flu virus and a coronavirus. Um, Even though physiologically the symptoms may be similar, fever, cough, uh, things like that, the two viruses have different mortality rates, which we don't really know what these are yet. We think that they're, 3.5% of the total population so far that we know of that has gotten the virus, 3.5% of them have died, mostly in the elderly and immunocompromised. However, there are people who have gotten this disease that are much younger, and these people still have severe symptoms, which require hospitalization, which require them to be on ventilators. And we think that the mortality rate for this thing has to do with the type of healthcare a country has. Which brings me to this. You've heard the term flattening the curve. What does this even mean? Okay, so we know this virus is spread from person to person, and we know that it's killing some people, and we know that it's causing severe illness in some people, and we also know that it's not causing severe illness in some people. So when you have a population and you have this virus loose within that population, what tends to happen is this: if we do not take measures to control the rate of infection, meaning if we cannot control how quickly this virus is spreading through a population, what ends up happening is that a lot more people will require hospitalization at the same time, as opposed to spreading it out over a longer period of time where the same amount of people may require hospitalization, except that it's not all at the same time. What this does is it allows the hospitals to recuperate and not stress them out with the number of beds, number of ventilators, medicine, palliative care, all that stuff. So that's what we mean by flattening the curve. And that's a term used by the statistical graphs that are developed through modeling of population genetics and population studies when you model a pandemic virus in a certain population. So, and then what you do that is you match that with the capability of your healthcare infrastructure. So if you're in a third world country where, like for example, Democratic of Congo, or in some, areas, some of these countries would have like one doctor per 100 people or something like that. And you have a massive epidemic or a pandemic of a virus like coronavirus, your threshold for being able to properly care for those who do need hospitalization is very low. And which means that the more people who get this disease, the faster they get it, the less likely they are to survive, because maybe 1 out of every 100 people has access to healthcare or a hospital, ventilators, things like that. So the rest end up dying. Now, let's move forward to, in these countries, these viruses wipe out communities very quickly. Now let's move to a more, more first world country, say even like Italy. Italy has a fantastic infrastructure, healthcare infrastructure. However, it too has a threshold, and this pandemic has caught that threshold off guard. Let's move to the United States. Um, we also have a threshold. There's only so many hospital beds, only so many doctors, only so many nurses that can work safely per a certain number of people in any given hospital or community. And once you reach that threshold, say, you're in a small community and you have a hospital that only has 100 beds and 100 ventilators, but because the rate of infection has spread so quickly, now all of a sudden on a Monday afternoon, 500 people show up with severe SARS, CoV-2, viral COVID-19 disease. Now what do? Well, 400 of these people are not going to be able to get health care. And what means is that you're going to see mortality rates go extremely high. So this is what we're talking about when we're talking about flattening the curve. The curve represents the concentration of people who are infected with a disease at a certain given time. So when the curve is more narrow, you have a lot more people infected, right, at a certain time. So if your threshold for hospital is, say, again, 100, but you have, 500 people all at once, you're not going to be able to, save a large number of those populations. Now, when we flatten the curve, okay, so we go from this to flatten, okay, now let's say 100 people get sick at a time, but only 100 at a time. Now the hospital is able to take care of 100 people at a time. As they get better, 100 more come in. Then we can treat them. As they get better, we release them and 100 more can come in. And now we can actually start to help the entire 500 group, because not everybody is coming in at the same time. So this is what we're talking about, flattening the curve. Okay? So I wanted to clear that out. And this is why it's important to do things like self-isolation, hand washing. We are trying to stop the rate of spread of this disease. Otherwise, we are going to overwhelm our medical and healthcare infrastructure, and we are not going to be able to help people. And we're going to see mortality rates go skyrocketing. Okay? If you see what's happening in a lot of these other countries like Iran, they're building literally like, looks like mass graves for people. Okay? So, we need to take this seriously. Now, who is this really affecting? It affects everybody. Some people have a mild case. Children, for some reason, are not being affected severely. We don't know why. We can't understand what that is yet. We don't know. And there's a lot we don't know about this virus, by the way, because it's new. That's the thing. It's new, but it's spreading on a global scale. We were expecting a pandemic like this for a while. Now, a lot of people are kind of saying, it's no big deal, right? And they carry on their lives and they don't care. Well, the problem is this. Let's say it's not a big deal, just for the sake of argument, even though it is a big deal. But let's say it's not. And let's say that this is a dress rehearsal for something even more severe. We're failing miserably. Imagine if Ebola becomes aerosolized and spreads as quickly as coronavirus, COVID-19. Imagine that. And we would be caught just with our pants down and mortality rates shooting up through 40, 50, 60% in all age groups. What then? So even if this was not a big deal, which it is, we are failing. Our infrastructure is weak. We don't have the type of preparedness that we need, even though scientists have been warning governments about this for a long time. But since science seems to be demonized these days, we're seeing the results of anti-science politicians and how they responded to this. So yeah, even if this was a dress rehearsal for something bigger, we suck and we need to change. So, this is about not politics. This is not about, you know, um, the election, even. This is about survival. Okay? Now, here's the thing, this is a big deal because people are dying. A lot of people are dying. And if we continue at the rate we're going, we're going to see a whole lot of deaths. And I hear people comparing this to the H1N1 flu during the Obama years. First of all, that's comparing apples and oranges. We haven't even seen the peak of this pandemic yet. We have not. So to compare those numbers is ridiculous. What we do know is that coronavirus, COVID-19, is 10 times more deadly than the common flu. Okay? 10 times. We're not really sure how to parse that data yet, but we're seeing a 10 time more mortality rate with people infected. So for the number of people that are infected, there's 10 times more people dying of coronavirus than the number of people who are infected with the flu who die. Okay? So it's a big deal. Plus, we don't know much about this. And we haven't gone through an entire year. So we don't know if this is going to end as the weather gets warmer in the summer. We don't know if this is going to stop like the flu. It may or it may not. We still don't know. And we won't know until we see it happening. So, how do we flatten the curve? How do we deal with this situation? How do we protect ourselves? There's a few things we can do. And a lot of, localities, states, municipalities are mandating some of these things. Number one being social isolation. We have seen the canceling of concerts, sports events, major things that are costing billions of dollars. We're seeing people being furloughed. We're seeing people losing work, money, livelihoods. Okay? All to prevent a disaster that is more than likely, if we continue at this rate, going to happen. So everybody has to take responsibility to help flatten this curve. So what can we do? Social isolation. Only go out when you need it to get supplies, to get things. Don't go out and hanging out. Don't go hanging at the beach like in Florida. Don't go, hanging out at a bar with a bunch of other people. Don't go to churches, congregation. Even churches are canceling their services. Okay, this is serious business. So social isolation until we start to see a downward trend, because right now we're not even at the peak. Not even at the peak. So social isolation, number one. What else can we do? Hand washing. Hand washing. This is a time-tested way to control cross-contamination and infection control. It's been something we have been using in the hospital infection control protocols and programs. Is all about hand washing. How do we stop disease from spreading from patient to patient in hospitals through the nurses and the doctors who see many patients a day? Between each patient, there is hand washing. Hand washing. Because when you go out to the grocery store and you get a cart that somebody else has used, you have no idea if somebody sneezed on that cart, somebody picked their nose and touched that cart. You have no idea. So even if you use the hand sanitizing wipes that they have now, which I highly recommend people do at grocery stores, and you wipe the handles of the cart. Say you go on the aisle with cereal and you go and you're like, you know what? I think I want some Cheerios. And you grab a box of Cheerios. And you're like, you know what? I want Frosted Flakes instead. You put the box back and you go grab Frosted Flakes. So somebody else comes behind you and grabs that same box of cereal you just grabbed. Well, guess what? Now we have seen a transfer of the virus one way. Okay. And so you multiply that by however many items that are in the store, by how many people frequent it, and you multiply that all by the chances of somebody having COVID. Which is why it's important that you then go home before you do anything, before you pet your dog, before you pick up your kids, before you do anything, you go and you wash your hands. And try your best, even though this is so difficult to do, try your best to not touch your face or eat anything until you do that. Then you wash your hands. Okay, wash your hands before you eat, wash your hands before you go to bed, wash your hands before you, after you come from being outside. Get in the habit of washing your hands. Now, hand washing. Don't just rinse your hands with water. Soap. Doesn't even have to be antimicrobial soap. Just regular soap will work, because the purpose of soap is to remove things off of your hand. So, soap. Then you lather and you wash and you do that for about 20 seconds. Sing a freaking song, any song at all. Make sure you get your fingernails. If you have rings, if you can remove your rings, you don't wash the rings too, wash underneath the rings. If you can't remove your rings like this one, do your best to get as much soap and rinse out of there. 20 seconds minimum. Good lather. 20 seconds. Like this. Okay? So, hand washing. Social isolation. 2 things. Thirdly, buy a good disinfectant. Okay? You can use things like 10% bleach, so you don't even have to buy any special thing. Just get household bleach and make a 10% solution. Then you can use, if you're allergic to bleach or if bleach is too harsh for you, you can use 70% ethanol, or 70 to 80% ethanol, or 70 to 80% isopropanol or isopropyl alcohol, or it's also called ethyl alcohol. Any of those will also work against this specific virus. Now, the key thing with making your own solutions. So if you use, say, a 10% bleach solution, you need to make sure that you make it fresh every day, because once you mix it with water and once it's exposed to light, it starts to have a decay rate where it's not as efficient. The other thing is that if there's lots of organic matter, it becomes less efficient. So if you're cleaning door handles, faucets, toilet seats, things like that, you should be okay. But if you're cleaning soiled material with lots of like blood, for example, you should probably use soap and water first to remove the organic material and then go over it with the disinfectant. Okay, so 10% bleach, that's all you need. You don't need any more than 10% bleach. That's going to be way more than enough to kill just about everything, by the way. Bleach is like the magic thing. But you can also use 70% ethanol or 70% isopropanol. Those have both been shown. Now you can use other things, and the EPA, there's a website you can go where EPA has listed approved SARS-CoV-2 disinfectants you can buy. Everything that Lysol makes, that Clorox makes, wipes, all these things. There's different things. The key thing is to make sure you pay attention to the contact time. Most viruses can be killed with these products anywhere between 1 to 5 minute contact time. So you don't just want to wipe it and then rinse it. You want to wipe it or spray it and let it sit for 1 to 5 minutes. Okay? In other words, let it air dry. and maybe wipe it again and let it air dry again, just to be on the safe side. These are things you can do too. So, cars, if you share a car, door handles of the car, steering wheels, the stick shift, excuse me, stick shift, anything people touch in a car, wipe that down regularly. Your house door handles, all of the door handles, refrigerators, sinks, faucets, showers, shower heads, all the handles, closet handles, door handles, anything that people share in a household, iPads, computer keyboards, telephones, cell phones. Okay? All of these things should be disinfected on a regular basis. Every time you wash your hands, technically, you should be disinfecting your cell phone first. Because if you wash your hands and you've been touching your cell phone all day, it could be contaminated. So you wash your hands, but the minute you touch your cell phone, it's contaminated again. Your hands are now contaminated again. These are all things you need to do. This is what we do, and this is the kind of protocols that I put in place whenever in my career, in my job, in my profession, which I'm a biosafety person or lab safety person. So, cross-contamination controls, things like that. So, hand washing, disinfection, social isolation. 3 big things right there. But you have to be really, really, really good at it. Like, you have to keep doing it. You can't just do it once a day. So when you wash your hands in a public restroom, okay, after you're done rinsing your hands and the faucet's still on, unless it's one of those automatic ones that's motion sensor, you're gonna have to turn it off. Well, that's probably contaminated. So you want to wipe your hands first and take the paper towel, use that to turn off, or use your elbow or something like that. If you're greeting people, by the way, elbow bumps are the way to do it. So these are some of the things you can do. Disinfection, social isolation, hand washing. Now, here's what does not work. You don't need to go out and buy and hoard N95 respirators. This is something you probably have been hearing a lot of. N95 respirators are to be used only by professionals like doctors and nurses and clinicians who have to treat patients that have COVID-19 and who are at an occupational exposure risk of getting the disease themselves because of the close proximity they have to be with to treat these people and make them better. If you hoard N95 respirators, you are taking it away from somebody who needs it. And you're taking it away from somebody who needs it to save a life. And you're hoarding this thing without even knowing that it is going to do zero to protect you. Okay? Just putting it on and walking outside is pointless. Don't do that. There are some specific criteria that are used to make sure that N95 respirators actually work. And if you don't know what these criteria are and you put this thing on, you're probably putting it on wrong, and it's probably not going to fit correctly, and it's not going to protect you anyway, and all it is doing is causing you to have a false sense of security. Don't do it. Now, here's what you do. If you do have symptoms, like a cough, like that. By the way, when you cough in public, elbow cough. If you do have symptoms, especially if these symptoms are coughing and sneezing, buy a surgical mask. These are not, people haven't run out of these. You can buy these on Amazon, whatever. Surgical masks are designed to protect everyone else from you when you're out in public and you're coughing and sneezing. So it's basically these masks you put on, usually to go around your ears. And when you're coughing and sneezing, it stops that 6-foot spread. So that's what you do to be responsible, to stop your illness from spreading if you have to go out, say a doctor, or to see a doctor, or to get, you run out of supplies at some point, you have to go to the grocery store. put on this mask in public. They're cheap. Not an N95 respirator. These are designed for occupational protection. People whose job it is to be around these sick people to protect themselves. Why we're at a shortage? Because there's a lot of idiots out there who have no clue what they're talking about or what they're doing, and they're thinking about hoarding these masks is going to somehow protect them. It's not. So, debunking some of these myths. All right, N95 respirators, unless you're working in an environment where you're at high risk from an occupational standpoint. And then, by the way, there are regulations involved. You have to be trained, fit tested. You have to go through a medical evaluation to make sure that these N95 respirators are not going to cause any respiratory distress. And they have to fit correctly. We actually do respiratory fit testing of these masks. And it's not one size fit all. Everybody's face is different. Everybody's, facial structures are different. So we have different types and different models and makes. And sometimes people will only fit certain kinds. But there's others that don't fit in any of them. And they cannot wear this respirator to protect them. So, yeah, don't do it. Facial hair like this, you can forget it. I mean, it's probably not going to help you much. It might help you a little bit, but facial hair sometimes it doesn't create a seal like you need. So that's the kind of thing that you need to think about. All right, so I think that's the big. Oh, let me talk about who's getting tested and who needs to get tested. So the different state departments of health have usually they take their cues from the CDC, and there are criteria that you must meet in order to be tested. So not anybody can just get tested for COVID. Now, in Virginia, the Virginia Department of Health updated their guidance on testing on COVID-19 as of March 13. And basically, in order to get tested, you need to do one of the following things. If you think you are sick, you must first go to your doctor or to the emergency room or to an emergency clinical center like Patient First or something like that. And they're going to do a screening. Now, there's 3 specific criteria you must fall under one or more of these in order for them to trigger the test. And it's this. The person the person must have close contact with a laboratory confirmed COVID-19 patient within 14 days of onset of the disease and must have a fever or signs, symptoms of a lower respiratory illness. So, number 1 is you need to be having close contact with somebody who is confirmed to have COVID. And not only that, you must also show symptoms, fever, other symptoms. So that's criteria 1. So if you live, for example, or if your roommate gets confirmed to have COVID-19 and you are like, oh crap, I probably have it, I want to get tested, but you're not showing any symptoms, they're not going to test you. You have to start showing symptoms. Fever, anything like that. So that's criteria 1. Criteria 2. The person has to have a fever or be clinically or radiographically diagnosed pneumonia requiring hospitalization. Okay, so you are either having a fever and have a clinical diagnosis or radiographically diagnosis, meaning x-rays or CAT scans or something like that show that you have pneumonia and you're required to be hospitalized, and you tested negative for influenza and other respiratory pathogens on a respiratory virus panel on your initial workup. So you go to the hospital, you're sick, okay, and they do an initial test and they find out you do have pneumonia. So they do a respiratory viral pneumonia test on you. Take some blood, take some sputum, whatever, and it comes back that it's none of the ones that we know that cause pneumonia, and there's no other diagnosis, then they'll test you for COVID-19. So that's the second one. The third criteria: if you are a person who resides in a nursing home or a long-term care facility, and you have a fever, or you have signs of respiratory illness, and you tested negative for other pneumonia viruses, and there's no alternative diagnosis, then they'll test you for COVID-19. Other than that, if you have a little cough and you're like, uh-oh, I got COVID, I want to get tested, you're not going to get tested. And the reason being is because we are lacking the test kits. What do we mean by the test kits? Well, to test for COVID-19 right now, the only way to do it is something called real-time PCR. PCR stands for polymerase chain reaction. In order to extract, and what PCR does is it confirms the RNA, or the nucleic acid of the coronavirus. So what they'll do is they take a swab sample of your nose, your throat, whatever, and they send these samples to the lab. Now, all the lab gets are these swabs. They need to extract the RNA from the viruses that are on these swabs. In order to do that, it requires some reagents, some chemicals, some things. And the companies that are making these reagents got caught off guard by the number of demand. And you can't just make these things up like that. It takes a while. So they're working on ramping up production, but we're still not there yet. Hopefully we're getting there soon. But this is what we mean by there's not enough test kits. Okay? It's the fact that we lack the reagents. Mostly it's one specific reagent that's used to actually extract the DNA from the virus. Now you gotta think, coronaviruses are envelope viruses, so they have an envelope, they have a protein, what we call a capsid, and inside this capsid is where the nucleic acid is, the RNA that we need to verify. To get that RNA out of these viruses, you need to do a couple of steps. You need to break that envelope, and then you have to break that protein capsid to get to the actual RNA. The reagent that does that is one of the reagents that do that is what is in short supply. So right now in Virginia, it's the Department of Consolidated Laboratories that are doing all the tests for a lot of the hospitals. So if you go to VCU Health Systems, where I work, if you get tested there, if you fall within one of these three criteria and you get tested, they're going to send your samples to the DCLS labs. These are state labs. And because these are part of the Virginia Department of Health, these are the criteria you get. Now, there may be some doctors or some hospitals that can ask a private lab, to do this test. And in that case, if your hospital healthcare provider has some sort of agreement with a private lab, not a state lab, but a private lab, then it's up to them to make that decision on whether you get tested or not. It doesn't have to fall within these guidelines. But if you go to a hospital that uses the state labs, then these are the criteria. That's how it is in Virginia. I have no idea what this is like in any other state. But this is what we're doing here. And I'm pretty sure it's pretty similar elsewhere. So, this is where we are. And it's exponentially growing. And the reason I think that the numbers are low in this country is because we haven't been testing enough people. That's my opinion. Because I guarantee you that the numbers are probably 4 to 10 times higher what we know they are, in my opinion. I could be wrong. But from what I know, this is the way it is. So, I think I hopefully answered as much as I could about this as far as I know. Again, I work in the field of biological safety. I'm a registered biological safety professional through the American Biological Safety Association. I've been doing this type of thing from a contamination control perspective and risk assessments in laboratory environments for 20 years now, over 20 years. This has been a career. I'm not a doctor. I'm not an epidemiologist. I'm not an infection control specialist. I'm a biosafety specialist. That's what I know. And, I know how to mitigate risk of exposure of various different things. That's what I know. Um, so take it or leave it. But the best thing to do when in doubt is go to your local, state Department of Health or the federal CDC. Don't go on the internet, on social media to get information. Or at the very least, verify it, unless it comes from a, a good source, like, for example, the CDC or things like that. All right, well, that's pretty much all I have to say. I hope this was useful. Again, I don't normally do these types of things. I was asked to do it. So I will, this is in, I'm a, hopefully it'll help some people clarify things. If I've confused people more than help, I apologize. Again, I just know what I know. And, and by the way, everything I said today in this video could change tomorrow with more information. We still do not know a whole lot about this virus. Things can change, and they are changing very quickly as we get more information. So, keep looking at your Department of Health websites. A lot of them have a special COVID-19 site up and running with up-to-date information as far as cases, number of tests, availability, things like that. That's where you need to go to get verified information. Not your Uncle Joe. Not even me. You don't know if I'm bullshitting this or not. But you can verify what I'm saying by going to these websites, these legitimate websites, and take the threat seriously. This is not a fucking joke. This is real. This is a pandemic. All right. Have a good one.